make it quick. So, just as a disclaimer, I will not anymore discuss anatomy, embryology, physiology, and other basic concepts that we expect the residents to already master even before they started residency, as well as signs and symptoms, risk factors, and other benign pathologies. So, just as an outline, we will be going through the diagnostic modalities, the approach to breast complaints. Majority of our topic will be on the management of breast cancer, which actually causes a lot of confusion lately with our trainees, and some special clinical situations with regards to breast pathologies. So first, for our basic diagnostic armamentarium for the breast, of course, we have our imaging and biopsy techniques. For mammography, it is essentially an X-ray image of the breast used for both diagnosis and screening. So there are two standard views, the craniocaudal and the MLO view. In the MLO view, when we see this shadow of the pectoralis muscle, that's where we look for any pathologic lymph nodes. So when we say it's a screening mammo, these are done on asymptomatic patients. So guidelines recommend to start screening at 40 years old. So minsan when you read through charts, ang daming age nakakalito. So 40 years old is when we start our screening mammo. While the diagnostic mammo is performed on a patient who comes in due to a breast complaint or has any findings on screening. So on screening mammo, we usually look for the suspicious microcalcifications. A diagnostic mammo on a patient with a breast mass would have this obvious finding. No? Now, I'm sure you've encountered patients who have results of DBT or digital breast tomosynthesis. So similar to a mammo, but if a mammo is 2D, DBT gives us a 3D image because multiple X-rays are taken from each breast at many angles. So the advantage is that it can identify tumors that conventional mammos alone cannot find, particularly in dense breasts, and they may also actually reduce the risk of a false positive result leading to further testing. So this is just an example of the comparison of a conventional 2D mammo with a tomosynthesis. No? So on the 2D mammo, you see this mass with calcifications. But with your tomo, you see that actually there are spiculated margins and this mass actually is larger than it looks on the 2D mammo. Similarly on the CC view. Next would be the breast ultrasound, which uses high-frequency sound waves to produce pictures of the internal structures of the breast, commonly used as an adjunct to diagnostic mammo. It can evaluate both the breast and axillary areas, and the axillary areas actually with more sensitivity than mammography. It can differentiate lesions as either cystic or solid, and is the initial imaging modality for patients less than 30 who present with any breast complaint, particularly breast masses. They can be used for screening in certain populations, particularly for women with dense breasts. So me, if I have a woman just going for screening, normally I would request for both a mammo and a breast ultrasound, particularly if they're quite young, 40s, 50s, a lot of times they still have dense breasts. Of course, when we do our interventions like biopsies, then we use the ultrasound to guide us. And we just expect that residents are able to differentiate benign and malignant breast masses on imaging. So on ultrasound, suspicious masses appear very hypoechoic, they're taller than wide or vertically oriented with irregular or angular margins. They may have this posterior shadowing. So don't forget this table. And all residents, I'm sure by now, are familiar with the BI-RADS category. So breast imaging, reporting, and data system acts as a guide for us as clinicians as to what to do with these breast patients that we encounter. So if you have a patient coming in, for example, with a breast mass, you only request for a mammo, and it comes out to be a BI-RADS 0, that doesn't mean that everything's okay. That means we need additional imaging, such as maybe a breast ultrasound. If your mammo and ultrasound are both still BI-RADS 0, these are the times when we may actually request for a breast MRI. BI-RADS 3 is probably benign, but there's still a small likelihood of malignancy, up to 2%. And so for these patients, we do advise short interval follow-up with repeat breast imaging in 6 months. So if your finding was on ultrasound, then we repeat the ultrasound in 6 months. If it's on mammo, we repeat the mammo in 6 months. But it's actually very important to counsel your patients, advise them to always check on their breast and to come back right away if they feel any significant increase in the size. I have encountered patients who had a BI-RADS 3 ultrasound months ago and then were not advised, and they come to me with very large, very obviously malignant breast masses. So it doesn't mean it's BI-RADS 3, it's benign. It still might be something malignant. So it's very important to advise patients. And of course, any BI-RADS 4 and 5 would warrant the biopsy. BI-RADS 6 is when you already have biopsy-proven malignancy, but we may request an imaging to better plan our surgery. Next would be breast MRI, which may be indicated when we still have inconclusive mammo and breast ultrasound results, when there is discordance in our clinical and imaging findings, like if you have suspicious physical exam with no findings on mammo or ultrasound, then we may consider doing a breast MRI. It may help us determine the extent of certain breast cancers, such as lobular carcinomas, and sometimes even we can use it to plan surgery when we're doing neoadjuvant therapy for these patients. No? So we can do a breast MRI pre and post neoadjuvant. It also may help us find occult primary cancers in patients who have axillary masses which turn out to be metastatic carcinoma from the breast, and to screen for certain breast cancer patients with higher risk, such as those with germline mutations in BRCA1 or 2. Next, we go to the different biopsy techniques. So I'm just showing this to highlight or to emphasize that there is really no more role for a fine needle aspiration biopsy in the biopsy of any solid breast mass. So we usually only use this if, for example, you have suspicious appearing lymph nodes in a patient also with a suspicious breast mass. Then we can do a fine needle aspiration biopsy of the axillary lymph nodes. Or if you have a patient with a symptomatic breast cyst, then we can do cyst aspiration. But for any solid breast mass that warrants a biopsy, then we do a core needle biopsy. Now, I only included this vacuum-assisted biopsy because I think not a lot of our residents are exposed to this, except maybe for those in high-volume, large tertiary centers where this is available. So a vacuum-assisted biopsy is actually similar to a core needle biopsy. You have a large bore needle which is able to take out strips of tissue, but it is actually attached to a machine and has a suction mechanism. And once you insert this needle, you can actually take several samples without having to reintroduce this. So this can be done under ultrasound or mammo guidance. And this is actually of particular use for patients who go for screening, who have findings of maybe suspicious microcalcifications on mammo. So under mammo guidance real time, while that breast is compressed in the mammo, this needle can actually take samples in real time, and we can actually see that those calcifications are being biopsied or removed. Next would be an open surgical biopsy when surgical excision, we do surgical excision when we cannot do a core needle biopsy on suspicious lesions such as masses at the area of the nipple, or when we have discordant results of our core needle biopsy, or for benign breast masses such as fibroadenomas. And we do image-guided open surgical biopsy with the insertion of needle or hook wires for non-palpable lesions seen on ultrasound or mammography. So this is just an example. A patient went for screening and had the suspicious architectural distortion. A hook wire was inserted, a partial mastectomy done, and that distortion is located in the center of that lesion. Now we go to the approach to the different breast complaints. So more often than not, our trainees don't really see patients who just go for screening. And more often than not, in the OPD, we would encounter patients who are actually symptomatic or coming in for a breast complaint. So what do we do? In general, most of the times, maybe 90% of the time, patients will come in due to palpable symptoms, such as a lump, a mass, thickening, or nodularity. And so all these algorithms I'll be presenting come from the NCCN guidelines for screening and diagnosis. So for patients who have a palpable symptom, who are greater than or equal to 30 years old, then we have to request for a diagnostic mammo and a breast ultrasound. For patients who are less than 30 years old, if we think that it's just hormone-related changes like lumpiness in the breast due to hormone changes, we may actually observe for about 1 to 2 menstrual cycles. But if the symptom persists, then we request for an ultrasound. Similarly, if it is clinically suspicious, so essentially, if you palpate a mass, even if it feels like a fibroadenoma or a breast cyst, for any patient with a palpable lump, if they're less than 30, we request for a breast ultrasound. And any BIRADS 4 or 5 result would warrant a biopsy, a core needle biopsy, if it is feasible. So as a summary, any palpable lump or symptom with clinical suspicion, for patients 30 and above, we do diagnostic mammo and breast ultrasound. Patients below 30, initial imaging would be a breast ultrasound. Any BIRADS 4 or 5 would warrant a core needle biopsy. Now, all these other symptoms, we will be going through them one by one, but in general, regardless of age, any of these new complaints would warrant both a diagnostic mammo and a breast ultrasound. So first, we go through nipple retraction. So if you have any new onset nipple inversion or retraction, which the patient claims has no palpable mass, which is new onset. So we have some patients who have inverted nipples ever since, but if you have new onset changes, then very important is to do a clinical breast exam. A lot of times they'll claim there's no mass, but actually maybe majority of the time you will actually palpate a retroareolar mass. You also try to check for any nipple discharge, and as well check for any signs of inflammation or infection. It might just be an infectious process. So is there any erythema, purulent discharge, any fistula from the skin to the areola, or any tenderness? So for any patient less than 30, if you're thinking of something that is probably infectious, then breast ultrasound would suffice. But for any other patient where you have a suspicion, you have a mass, and for any patient 30 and above, then we do a diagnostic mammo and a breast ultrasound. For those patients who have BIRADS 4 or 5 results, then we do a biopsy. And as I mentioned, there are certain instances where it would be not feasible or difficult for us to do a core needle biopsy, even ultrasound guided, such as cases like this. So in cases like this, we might need to do a surgical excision if the lesion is not amenable to a core needle biopsy. Now, if our imaging results turn out to be benign or negative, or even BIRADS 3, but to us looks clinically suspicious, then we may consider referring to a breast surgeon, or we may actually request for a breast MRI with contrast. So in general, when we do breast MRI, you'll see the guidelines say with or without contrast, but actually, we actually need the contrast to be able to differentiate malignant and benign findings, because it's the kinetics that the radiologists look at to be able to determine if something is suspicious or not. Any abnormal clinical or MRI imaging findings warrants a core biopsy. So locally, nobody does MRI-guided core needle biopsies or localizations yet. So normally, if you have something suspicious on MRI, what we do is we send these patients back to the breast radiologist for a second look breast ultrasound. And more often than not, they will be able to find something in the area where there was a suspicious finding on MRI. And this is what we target for our core needle biopsy. Next will be nipple discharge. So very important to be able to differentiate physiologic and pathologic nipple discharge. So physiologic is usually bilateral, involves multiple ducts, and may be milky, while pathologic discharge is usually bloody or serous, such as these images. They're usually uniductal, meaning like these, they come from one duct, unilateral, and spontaneous. So a lot of times these patients will claim that they just noticed stains of blood or fluid on their bra or on their shirt. So for any patient with a pathologic nipple discharge that is persistent and reproducible, meaning when you do your physical examination and you press on the breast, you're actually able to elicit that discharge coming out, then regardless of age, we do a mammogram and breast ultrasound. If our mammo and ultrasound is benign, negative, or BIRADS 3, we may do a breast MRI with contrast. And if it turns out looking benign, we may follow up these patients or do a duct excision. In patients with BIRADS 4 or 5 findings, then a core needle biopsy or surgical excision is done. Now, if you take a look at this, we may do duct excision. If your core biopsy is benign, we still do a duct excision. So normally, in my practice, if I have a patient with spontaneous nipple discharge that's pathologic, with benign findings on imaging, I usually have them come back to me after 4 to 6 weeks. And if on that follow-up I can still elicit that discharge, then I just go ahead and schedule them for a duct excision or a microductectomy. More often than not, they just turn out to be intraductal papillomas, but sometimes they still turn out to be malignant, such as ductal carcinoma in situ. Next would be skin changes that might be suspicious for inflammatory breast cancer or Paget's disease, such as erythema occupying more than 1/3 of the breast, dysedema and peau d'orange, or any nipple excoriation or crusting or ulcerations. So when we have patients with skin changes suspicious for inflammatory breast cancer, including these symptoms, or suspicious for Paget's disease, including nipple excoriation, scaling, or skin ulceration, regardless of age, we do a diagnostic mammo and ultrasound. If the results are benign, then we may consider again doing a breast MRI, and with any abnormal findings, a biopsy is warranted. If there is no finding, then we usually do a skin punch or incision biopsy of the skin or of that nipple lesion. If we have any findings in the breast, which is BI-RADS 4 or 5, then we do a core needle biopsy. If it's still benign, then we usually still do biopsy of that skin or of the nipple and consider MRI. Now, when we have patients presenting with an axillary mass, it's important to do a complete clinical evaluation, assess for other sites of adenopathy, the cervical, both axillary and both inguinal areas, elicit any other potential causes of the adenopathy. In the Philippines, tuberculosis is very common. Lymphoma could be another cause. So you try to elicit B symptoms, fever, chills, night sweats, weight loss, or any evidence of other conditions known to be associated with systemic adenopathy, such as lupus, rheumatoid arthritis, HIV, and others. Also, since the COVID pandemic, we have increased the number of patients coming in due to palpable adenopathy or suspicious adenopathy seen on imaging. So you ask about vaccination status because a lot of times these are just reactive lymph nodes which they come with. So in a patient with an axillary mass expected to represent adenopathy, if it is bilateral, again, we look for systemic disease and manage as necessary. If no other systemic disease, or if it is unilateral, then we do diagnostic mammo and breast ultrasound. Any suspicious findings warrants a tissue diagnosis or a core needle biopsy. So if you have a malignant axillary node of non-breast origin, such as lymphoma, then we treat as such. If you have a malignant node and breast cancer, we treat as such. But if you have a malignant axillary lymph node, but no findings on the breast, or you have a breast lesion but which turned out to be benign, like a fibroadenoma, then the next step to do will be to do a breast MRI to look for any occult primaries. So what do we do after our core needle biopsy? So if the result of our core needle biopsy is benign and concordant with imaging findings, meaning the result of your biopsy has to match the appearance on imaging. If it is concordant, then we just send these patients back to their usual screening. But if the result is benign but image discordant, or for other specific histologies such as flat epithelial atypia, papillary neoplasms, but discordant with imaging, then surgical excision is warranted. Indeterminate biopsy results, we may consider a repeat ultrasound-guided core needle biopsy. So if you have a patient, you did a blind biopsy, it's benign and discordant or indeterminate, the next step would be to do it ultrasound-guided. And if the result is still indeterminate, then we go ahead and do surgical excision. If you get a typical ductal hyperplasia or non-classic lobular carcinoma in situ, so non-classic LCIS would be pleomorphic and florid LCIS, then surgical excision is warranted. And when we do our surgical excision and we encounter these, a typical ductal hyperplasia, a typical lobular hyperplasia, classic LCIS or non-classic LCIS, wide or negative margins is not necessary. Meaning if you excised it, this is the result, but you have positive margins, that's okay. No need to go back for further margins. No need for radiation therapy. And so these tables are lifted from Schwartz just to show that ALH and ADH, you have a four-fold increase in the relative risk of developing invasive carcinoma down the line. LCIS and DCIS, the risk is tenfold. Now, this table just shows us why we manage LCIS and DCIS differently. DCIS is a pre-malignant lesion, meaning if untreated, it eventually will become invasive carcinoma. So in DCIS, the incidence of subsequent carcinoma is as high as 70%, usually in the same breast and usually same histology. While LCIS normally the subsequent carcinoma can be on either breast, not necessarily where the LCIS was, and the histologic type would still be ductal, which is the most common histology for breast cancer. So LCIS is just a high-risk lesion or a marker for an increased risk. DCIS is actually pre-malignant. Next, we go to the management of breast cancer. So before we go to the management, knowing the staging is very important because the management will determine, the stage will determine your management. So for the T stage or the tumor size, it's quite easy to remember. Just memorize T2. T2 is greater than 2 cm but less than or equal to 5 cm. So if it's smaller than that or less than or equal to 2 cm, that's a T1. Anything greater than 5 cm is a T3. Anything that involves the skin, you have ulceration, you have skin nodules, would be a T4, as well as direct extension to the chest wall. Very important, invasion or adherence to the pectoralis muscle in the absence of invasion of chest wall structures, that means intercostal muscles or ribs, does not qualify as a T4. So if you intra-op your surgery, you had to shave off muscle from the pectoralis, that is not considered a T4. Now, inflammatory breast cancer is considered automatically T4D. Now, I added this, very important to highlight, you also have to know the difference of a T1A, T1B, and T1C because the management also differs depending on this. No? So just remember, T1C is more than 1 cm up to 2 cm. T1A is 5 millimeters or less. For nodal staging, clinical and pathologic is different. So for clinical nodal staging, palpable movable nodes in the ipsilateral axilla is N1. If it's fixed or matted, or if on imaging you have internal mammary nodes, that's N2. And if you have involvement of infra or supraclavicular nodes, then that is N3. Pathologic nodal staging depends on the number of positive nodes once you do your axillary staging or axillary dissection. And your M1 just means you have distant metastasis. Now for staging, it might be confusing, but it's actually also quite easy to remember. So first of all, stage 1B, kalimutan nyo na yan. You probably will not encounter stage 1B in your exams. So first, we look at 1A and 2A, which is just the T stage with no nodal involvement. So stage 1A is T1N0. Stage 2A is T2N0. Now, once you have any nodal involvement, you go up to the next stage. So a T1N1, you skip 1B, like I said, T1N1 would be a stage 2A. T2N1 would be a stage 2B. Now, let's skip that muna. Stage 4 is any patient who has distant metastasis. Stage 3C is any patient who has N3 disease. Stage 3B is any patient who is T4. And stage 3A is any patient who is N2. So yung pampagulo lang actually yung T3 because T3N0 is 2B and T3N1 is 3A. All the rest are quite easy to remember. So siguro memorize nyo na lang yung T3. T3N0 is 2B, T3N1 is 3A. Now, this is the traditional approach to the treatment of breast cancer. So, during my residency, this is how we used to treat all our breast cancer patients. So, traditionally, we would do upfront surgery for all patients, except in cases of locally advanced breast cancer, which is inoperable. So, in locally advanced breast cancer, we would give pre-op systemic therapy just to make it operable. So, uso pa dati yung sandwich technique. We give 3 cycles, do the surgery, and then complete the chemo after surgery. This would be followed by, if indicated, adjuvant chemotherapy. So it's important to know this so that if your patients ask you, you're able to counsel them. So chemotherapy usually would be given for 6 to 8 cycles. Normally, it's every 3 weeks, and the total duration would be more or less about 6 months. If the patient has a HER2 positive or HER2 enriched cancer, then we add on targeted therapy such as trastuzumab and pertuzumab. And in general, this is given for a total of 18 cycles or a total of 1 year. Now, if indicated, radiation therapy is usually given after chemotherapy, and conventional fractionation would be 30 fractions given daily from Monday to Friday for about 5 to 6 weeks. So when patients ask, gaano katagal yung radiation, doc? Normally, 5 to 6 weeks, you'll tell them every day, Monday to Friday, you have to come to the hospital. However, now there are already hypofractionated regimens where RT may be delivered over 15 or 16 days, or sometimes even only 5 days, ultra hypofractionation. If the patient is HER2 positive, once they've completed chemo and go for RT, trastuzumab may be given concurrently with RT. If their tumor is estrogen receptor positive, again, anti-estrogen therapy may be given concurrently with radiation therapy. Anti-estrogen therapy is not given concurrently with chemotherapy. No? So don't forget this. This is also very helpful when your patients ask you about all the other treatment that they need to receive. So that was traditional approach to treatment. However, it's already 2025 and we have a deeper understanding of breast cancer, its biology, and its behavior. And so maybe for the past 5, 6, or 7 years, what I presented earlier is no longer standard of care. No? So it's very important to know the different breast cancer subtypes. Luminal A would usually be low grade. They're usually strong ER/PR positive and HER2 negative. And if we request for proliferative indices like Ki-67, it would be low. So luminal A cancers have the best prognosis. Luminal B, similarly, would be estrogen receptor positive. It might be as high. Progesterone receptor may be positive or negative, and HER2 may be positive or negative. Ki-67 would be high. So compared to luminal A, luminal B cancers would have poorer prognosis. HER2 enriched cancers are usually high grade, ER/PR negative, HER2 positive, and basal-like or triple negative breast cancers have the poorest prognosis. 15 to 20% would have BRCA mutations, and they're triple negative. Now, I included ALRED score because I heard that a lot of the trainees or maybe even a lot of the graduates going for oral exams are not very familiar with this. So ALRED score is actually the way that the pathologist would grade the findings when they do immunohistochemical stains for estrogen receptor and progesterone receptor. So their score would depend on the percentage of stained cells as well as the intensity of staining. So you're not expected to actually know this. But if you're presented with an ALRED score, what's important is that you know that an ALRED score of 0 or 2 means that it's negative. So if your estrogen receptor staining is in less than 1% of cells and weak, that's an ALRED score of 2, then that would be negative. While if you have an ALRED score of 3, 4, 5, 6, 7, 8, for example, 100% staining, strong, an ALRED score of 8, then that would be estrogen receptor positive. It's the same for progesterone receptor. For HER2 new immunohistochem, if you get a score of 0 or 1 plus, that is HER2 new negative. If you get a HER2 of 3 plus, that is positive. If the HER2 new is 2 plus, that is equivocal, meaning we have to do further testing with FISH to confirm if the patient is HER2 new positive or negative. So sometimes the cases will not indicate if it's estrogen receptor positive or negative. Nakalagay lang ALRED score. Or yung HER2 new, it won't indicate if it's positive or negative. Nakalagay lang din yung score. So you have to know this. Now, compared to what I previously presented, this would be the approach now in 2025 to a patient newly diagnosed with invasive carcinoma. So for a patient with localized non-metastatic breast cancer, of course, we do our history and PE. Sometimes you get patients with a biopsy of invasive carcinoma, but with no breast imaging. So without any breast imaging, we complete that because this will guide us as to our surgical options that we can offer to the patient. And of course, we have to request for the IHCs for ER, PR, and HER2/neu. Now, for luminal cancers, estrogen receptor positive, HER2/neu negative, for early breast cancer that are operable, we usually send them straight for upfront surgery. For patients with locally advanced or inflammatory breast cancer of any subtype, so usually this would include patients with T4 tumors or N2 to N3 clinical nodal status. Of course, we have to do complete metastatic workup. These are advanced disease. So we do usually CT scan of the chest and abdomen and a bone scan to rule out metastasis to the bone, lungs, and liver. Or we may sometimes even consider doing a PET CT scan. If the patient has any distant metastasis, then there is actually no significant role for surgery. If there is no sign of distant metastasis, then again, we send the patient for preoperative systemic therapy. Now, very important is this center. Kaya sa gitna ko siya linagay. Because this is something that is still not very widely practiced. But you guys as residents have to know that this is already standard of care. And this is how you should be managing your breast cancer patients. So for patients who are triple negative or HER2 positive, regardless of estrogen receptor status, for tumors that are T1C or higher, so T1C, sabi ko, di ba, yung 1 cm ang cut-off, or node positive with no contraindications to chemotherapy, then ideally, we send these patients for preoperative systemic therapy. So in the past years, actually the cutoff was T2. My lecture last year, T2 pa to. But if you look at the new NCCN guidelines, it's actually already recommended for patients with T1C tumors, no? And when we send patients for pre-op systemic therapy, it's important that all chemotherapy is completed prior to surgery. So it's important to have your patients come back to you after every 2 cycles. You reassess the breast for response because our goal is to achieve a pathologic complete response, meaning we want to max out that chemotherapy so that hopefully by the time we do the surgery, there is no more residual cancer. Now, surgery for breast cancer involves surgery to the breast as well as surgery to the axilla. Surgery to the breast could be either a partial mastectomy, also known as wide excision, lumpectomy, quadrantectomy. So any removal of that tumor with a margin of normal tissue, or a mastectomy, either the most common, a total or simple mastectomy, or for certain cases who are good candidates, we may offer nipple or skin sparing mastectomy with reconstruction. Surgery to the axilla would include sentinel lymph node biopsy or axillary lymph node dissection. Now, very important, axillary staging is usually not warranted in cases of ductal carcinoma in situ. So in the surgical management of ductal carcinoma in situ, we may offer breast-conserving surgery, which would comprise a partial mastectomy followed by radiation therapy. Or if the DCIS is extensive or the patient really doesn't want to go for RT, then we can do a mastectomy, either a total mastectomy or mastectomy with reconstruction with a sentinel lymph node biopsy. So, baka sabihin nyo, bakit may sentinel lymph node? Sabi kanina, it's not warranted. So, in patients with biopsy-proven DCIS who were diagnosed by a core needle biopsy, there's actually a 20% upgrade rate to invasive carcinoma. So, it's possible that the area you sampled was DCIS, but in 20% of cases, part of that lesion might have some invasive component. And we do a mastectomy, we won't be able to do a sentinel lymph node biopsy anymore. So during the same setting, if we're doing a mastectomy for a DCIS, then usually we would do a sentinel lymph node biopsy as well. We do not do axillary dissection. So these are certain instances where we may consider doing sentinel lymph node biopsy for ductal carcinoma in situ. As I mentioned, mastectomy. When we have clinical or pathologic suspicion of invasion or axillary metastasis, for example, your core needle biopsy turned out to be DCIS with an area suspicious for microinvasion. Or if on your breast imaging, you had suspicious lymph nodes, although biopsy proven benign, then we may consider SLNB. If our lumpectomy would be in a location compromising future performance of SLNB, such as periareolar area in the upper outer quadrant, or if you're doing oncoplastic breast conserving surgery, then we may consider doing sentinel lymph node biopsy. But in general, if we're just doing a lumpectomy, usually we do not do any axillary staging. Now, surgery for invasive breast cancer, we have a lot of options. For BCS, it would include a partial mastectomy and RT, but we add on our surgical axillary staging by means of either a sentinel lymph node biopsy or an axillary dissection. These are the contraindications to BCS, so please just look through them in the NCCN guidelines. We don't have time to discuss. Another option would be a mastectomy with axillary staging. So when you say mastectomy, you remove the entire breast and nipple areola complex. Axillary lymph node dissection includes removal of levels 1 and 2 axillary lymph nodes. And of course, we have an option for mastectomy with reconstruction. It can be a skin sparing or nipple sparing mastectomy with either an implant recon or autologous reconstruction. So it's important for the breast surgeon, the general surgeon, to work hand in hand with the plastic surgeon to best plan what reconstructive options would be best for your patient. Now, when we're doing breast conserving surgery, of course, margins are very important. And so if you're doing a BCS for DCIS, you need at least 2 millimeter of margin. For invasive carcinoma, no ink on tumor is an acceptable margin. If you have a DCIS with the focus of microinvasion, we still follow the 2 millimeter margin. But if you have an invasive cancer with DCIS, then we follow the no ink on tumor. So of course, intraoperatively, we grossly try to get 1 cm margin around our tumor. But this is helpful if on final histopath it turns out that, for example, it's invasive cancer and the margins are less than 1 millimeter. As long as there's no ink on tumor, that's already acceptable, as long as your patient is going for RT after. Also very important, these are margin guidelines for breast conserving surgery. So if you're doing a mastectomy, then every effort must be made to do adequate surgery and not have inadequate margins, because this might be an indication for radiation therapy when the patient had no other indications at the outset. So it's important to do your surgery properly. Next, for axillary staging, we do sentinel lymph node biopsy, ideally for patients who are clinically node negative. So we can inject either a radiocolloid or a dye, either peritumoral or subareolar. And this dye or radiocolloid will travel to the axilla and help us identify the sentinel nodes, which would be the first nodes to drain the breast. Normally, we only do sentinel lymph node biopsy for patients who have tumors that are T1 to T2 and clinically node negative, meaning no clinically palpable nodes. So now we are expanding the indication for sentinel lymph node biopsy, but the data is really only very strong for these particular cases. So for your level, okay na yan. Basta sentinel lymph node biopsy, T1 to T2, clinically node negative. So this is the latest NCCN guidelines. It might cause some confusion. That's why I added it, no? So if you see here, considerations for surgical axillary staging, no palpable lymph node at diagnosis, or limited axillary node involvement on imaging confirmed by needle biopsy in the most suspicious node. So this one actually tells us kahit may positive lymph node, we can do sentinel lymph node biopsy. So when we say limited axillary node involvement, that means only 1 or 2 abnormal looking lymph nodes on imaging with no palpable lymph node. Okay? So even if biopsy proven, if you only have 1 or 2 suspicious nodes, the patient can actually still go for sentinel lymph node biopsy. And this is because of this. So normally in the past, any positive sentinel lymph node, we would go ahead and do an axillary lymph node dissection. However, the ACOSOG Z11 trial, the AMAROS trial have showed us that for certain cases, we may actually omit an axillary dissection if your patient will be going for radiation therapy. So for example, you have a patient who meets all of this criteria, T1 to T2, clinically node negative. Please, itong T3, bagong dagdag lang din to. But if you look at this, this letter E, it just says that there's limited data. So forget about this T3. T1 or T2 lang tayo. So if you have a patient who meets the criteria of T1 to T2, clinically node negative, did not go for neoadjuvant therapy, and you only have 1 to 2 positive lymph nodes, and they're going for RT, like if they went for breast conserving surgery, then we don't have to do an axillary dissection. If they do not meet this criteria, for example, you had 3 positive sentinel nodes, the tumor was larger, or the patient is post-neoadjuvant, then an axillary node dissection is warranted, no? So clinically N0, if you have suspicious nodes on imaging, biopsy proven. If there's 1 or 2 nodes only, we may still consider sentinel lymph node biopsy, particularly for luminal cancers who will not go for neoadjuvant therapy and who may possibly meet this criteria. That's why nasama sila dyan. So again, just to clarify, for omission of axillary dissection, even if the sentinel node is positive, this is based on ACOSOG Z11 trial, this is the criteria you have to memorize. Clinical T1 to T2, clinically node negative, no neoadjuvant, only 1 to 2 positive sentinel nodes, and whole breast RT or adjuvant RT is planned. Now, for any patient with clinically palpable nodes, biopsy proven to be malignant, so ideally all suspicious nodes, we also do a biopsy. Particularly, we send these patients for neoadjuvant therapy. So if our biopsy is positive, we do consider pre-op therapy, particularly for those who are TNBC or HER2. If no pre-op therapy, axillary dissection. If with pre-op therapy and still node positive, axillary dissection. So this one might also cause confusion. So for patients who are node positive, who convert to node negative after neoadjuvant, we may consider sentinel lymph node biopsy. But baka masyado na yun advanced para sa inyo. Hindi naman siguro itatanong. But if we do sentinel lymph node biopsy in the post-neoadjuvant for these cases, normally we have to use dual tracer. We have to get at least 3 sentinel lymph nodes, no? Pero hindi na siguro yan itatanong. Basta node positive, palpable node, usually axillary dissection dyan. Next, we go on to adjuvant systemic therapy. So there are different systemic therapy that can be given. Of course, we're all familiar with cytotoxic chemotherapy. For estrogen receptor positive cancers, we give anti-estrogen therapy such as selective estrogen receptor modulators like tamoxifen for premenopausal women, aromatase inhibitors like anastrozole, letrozole for postmenopausal women. For young premenopausal high-risk patients, we may add on ovarian function suppression to their anti-estrogen therapy. And in patients with DCIS who underwent a breast-conserving surgery, we also give anti-estrogen therapy. Targeted therapy or anti-HER2 therapy includes trastuzumab, pertuzumab, and TDM1 or trastuzumab emtansine. And we also have newer agents such as CDK4/6 inhibitors such as abemaciclib and ribociclib, which is given for high-risk luminal cancers. PARP inhibitors, which is given to BRCA mutation carriers. So, pag may nakita kayo dyan na may olaparib tapos may BRCA, yun na siguro yung sagot doon. And then, immunotherapy such as pembrolizumab for triple-negative breast cancer. So, last year, I didn't really highlight these. But this year, I think it's already important for everyone to know kasi it's already standard of care na, no? Hindi na sila investigational. So we will go through the different tumor subtypes and systemic therapy recommendations. So I highlighted the size. So in general, any node positive warrants adjuvant chemo. So for triple-negative breast cancer, we will usually recommend adjuvant chemo if your tumor size is 0.6 cm and larger. In the post-neoadjuvant setting with residual tumor, we may give additional adjuvant treatment like capecitabine, pembrolizumab, or olaparib. So I created this algorithm again just to show you why. Why do we give this pre-op systemic therapy even for early triple-negative breast cancer? So if you have a patient newly diagnosed with triple-negative breast cancer who is clinical T1C or more, node positive, we would send these patients for neoadjuvant therapy, complete everything, and then send these patients for surgery. Our main goal is to achieve a PCR or a pathologic complete response. If they attain a PCR, then we just continue with our planned management. Like if they need radiation therapy, we give that. If they have BRCA mutation, we may give olaparib. If they do not, so doing this neoadjuvant actually is for these patients who do not achieve a PCR after completion of neoadjuvant therapy. For triple negative patients who do not achieve a PCR, then we can add on adjuvant capecitabine, which, based on the CREATE-X trial, really significantly improved disease-free and overall survival in these patients. No? So that's why we do this, because we are trying to get them to live as long as they can possibly live, not have a recurrence. And adding on this adjuvant capecitabine to those who don't get a PCR significantly improves disease-free survival. Now, again, I said a new thing which is already standard of care would be the addition of immunotherapy. So before, immunotherapy was only used for metastatic breast cancer, but now there's really shown benefit of giving neoadjuvant immunotherapy with pembrolizumab for any patient who have stage 2 to stage 3 triple negative breast cancer. No? So if the patient can afford, besides the chemotherapy, we add on immunotherapy in the neoadjuvant setting and continue that at the adjuvant setting. Okay? So don't forget this. Next, similarly for HER2 positive cancers, again, adjuvant systemic therapy is indicated if, so we give chemo with targeted therapy if the tumor is 0.6 cm and larger, same as triple negative, or node positive. For these patients, if they are T2 to T3 or node positive, ideally we use dual anti-HER2 of trastuzumab with pertuzumab. Now, in the post-neoadjuvant setting, they must complete all 18 cycles. So, diba I mentioned earlier, 1 year kasi to. So, in the neoadjuvant setting, trastuzumab is given with chemo, but they won't be able to complete everything. So, for example, they only got 4 trastuzumab pre-op, then the other 14 has to be completed post-op. Now, in patients post-neoadjuvant with residual tumor, then ideally we shift this trastuzumab to TDM1 or trastuzumab emtansine for 14 cycles. If they are ER positive, then in addition to the targeted therapy, we also give endocrine therapy. So similar to triple negative breast cancer, T1C or node positive, neoadjuvant chemo with targeted anti-HER2 therapy. If they achieve a PCR, then you just complete that trastuzumab for a total of 18 cycles, or trastuzumab and pertuzumab. But if they do not achieve a PCR, ideally, we want to shift these patients to a TDM1 or trastuzumab emtansine, which is a trastuzumab conjugated to a chemo drug, for 14 cycles. And based on the Catherine trial, again, this improves overall survival. No? So even if it's early, very easy to do a BCS, very easy to operate on these patients. We do this neoadjuvant therapy to improve our overall survival and disease-free survival outcomes. Now, more confusing would be how to recommend adjuvant therapy for patients who have luminal cancers. No? Kasi dito na pumapasok yung mga genomic assays. So, if you look through NCCN guidelines, it would recommend yung 21-gene RT-PCR or the Oncotype DX. So, when do we request for this? So, if you look through the algorithms, it's really quite confusing. So, I tried to simplify it so it's easier for you to memorize or remember. So, ideally, any patient who has an estrogen receptor positive, HER2 negative cancer gets sent for an Oncotype DX if tumor is more than 0.5 cm. In premenopausal women, if they're node negative, for postmenopausal women, we can include those who have 1 to 3 positive lymph nodes. Now, important in this parenthesis, I included pathologic T1 to T2. Kasi sa NCCN, again, it doesn't indicate. But all the trials, like the TAILORx trial, RxPonder, majority of the patients in those studies had a mean tumor size of about 2 cm. So patients with larger tumors are not really well represented in those studies, and so we only usually do these genomic assays for pathologic T1 to T2, no? More than 0.5 cm. So kung T3, normally chemotherapy na yan. And I also made a table with the different recurrence scores to make it easy to remember. So any Oncotype DX recurrence score greater than or equal to 26 would warrant chemotherapy followed by endocrine therapy. For postmenopausal women, a recurrence score less than 26, there's no benefit to giving chemo, and we just give endocrine therapy. For premenopausal women, it's different. So for those who have a recurrence score of 16 to 25, there is still some benefit to the chemotherapy. Although they couldn't tell, is the benefit because of the chemotherapy effect, or is it really just the effect of the chemotherapy on the ovaries? And so in these patients, usually I would recommend still chemotherapy. But if the patient refuses, then we may give endocrine therapy with ovarian suppression. For recurrence score less than or equal to 15 for premenopausal, then we can give endocrine therapy with ovarian function suppression. So those cutoffs are based on this. So in the study in TAILORx, for women who had 26 to 100 recurrence score, regardless of age and nodal status, there was really substantial benefit to giving chemotherapy. However, in postmenopausal women or women above 50, if they were node positive, even if they were node positive, there really was no chemo benefit, even with a recurrence score up to 25. For premenopausal women who were N1, regardless of score, there was really still some chemo benefit. That's why N1 premenopausal, we don't do oncotype. While if they are premenopausal with a recurrence score of 16 to 25, there is still some benefit to the chemo, no? So this is the rationale behind these numbers. So, tandaan nyo na lang yung 26 tsaka yung 15. Okay. Now, siguro 99% of Filipino patients will not actually have an Oncotype DX done. So, if Oncotype DX is indicated but not done, then we still recommend adjuvant chemotherapy, and the cutoff would be more than 0.5 cm and node positive. So actually, it's same as triple neg and HER2, except yung sa HER2 and triple neg is stated as 0.6. In luminal, it's stated as more than 0.5. But more than 0.5 cm is actually 0.6 cm. So, same lang naman, no? So, any luminal patient who cannot do oncotype but more than 0.5 cm tumor and node positive, chemotherapy is usually indicated, followed by endocrine therapy for at least 5 years, tamoxifen or aromatase inhibitor with ovarian suppression for premenopausal, aromatase inhibitors for postmenopausal. For high-risk patients, we add on CDK4/6 inhibitors. Now, important, merong nakalagay dun sa NCCN. For postmenopausal women with T1B, so that's between 5 mm and 1 cm, if it is low grade with no lymphovascular invasion, no chemotherapy for these patients and endocrine therapy alone may be given kasi hindi rin sila well represented in the trials. Otherwise, premenopausal or larger tumor or higher grade, lahat yan kung walang oncotype, we recommend chemotherapy. Now, I added this because it's something new but it's already also standard of care. So for luminal patients with high-risk breast cancer, on top of the endocrine therapy, we also recommend adjuvant CDK4/6 inhibitors. These are also oral medications, no? So based on the NATALEE and Monarchy trial, it's really shown to add benefit. So abemaciclib is usually given for 2 years, ribociclib for 3 years, along with the anti-estrogen therapy. So these would be the indications. So for abemaciclib, based on their study, greater than or equal to 4 positive nodes or 1 to 3 positive nodes, which is with either of the following grade 3 or larger tumor size. For ribociclib, any node positive was actually, it's already indicated. Larger tumor size greater than or equal to 5 cm, or if you have a tumor size that's T2 but grade 3, or grade 2 with a high genomic risk or an oncotype score more than 26, or a Ki67 greater than or equal to 20, then these CDK4/6 inhibitors are indicated. So a lot of times these high-risk patients would first go for chemotherapy, then when they finish their chemotherapy, then we start them on their anti-estrogen therapy with the CDK4/6 inhibitor. Next, we go on to the last, which is adjuvant radiation therapy. So what are the indications for RT? Conventionally, post-mastectomy patients, we would recommend RT for patients with tumor more than 5 cm, any positive lymph node. So during my time in residency, 4 or more. But now, even 1 positive node, studies show that there is really not just improvement and locoregional control, but even survival benefit to giving adjuvant radiation therapy to patients who have even just 1 positive axillary node. So positive node is an indication, as well as closed surgical margins in patients you did a mastectomy on. So that's why I said earlier you have to do proper surgery. So if you have a patient, for example, with a 4 cm tumor, no nodes, pero it turns out yung margin mo is less than 1 millimeter, then they will have to go for RT when they had no other indications. We may also consider post-mastectomy RT in patients with multiple high-risk recurrence factors such as central or medial tumors or T2 tumors with at least one, either grade 3, estrogen receptor negative, or LVI positive. So this is why it's important to actually have multidisciplinary management of our breast cancer patients, because not all of the time we know the indications. We might not be referring them to rad onco when in fact there is an indication for radiation therapy. Next indication, all patients after breast conserving surgery. So as we know, part of your breast conserving surgery is the radiation therapy. Omission of RT in these cases results in increased recurrence as high as 50 to 70% chance of ipsilateral breast cancer recurrence, no? But new studies have shown that we may consider omission of RT if the patient has no positive nodes, pathologic and zero, and they are planned for adjuvant endocrine therapy anyway. If they are greater than or equal to 65, hormone receptor positive, HER2 new negative, pathologic node negative, and tumor size less than or equal to 3 cm. This next bullet, baka ma-confuse, greater than or equal to 70, hormone receptor positive, clinically node negative, pathologic T1, less than or equal to 2 cm. So for this one, so we have the new data to show that we may actually omit sentinel lymph node biopsy in certain subsets of patients, such as these elderly luminal stage 1 cancer patients. So these patients may also omit RT. However, ito na lang yung tandaan nyo. 65, hormone receptor positive, HER2 new negative, pathologic and 0 with tumors less than or equal to 3 cm. We may consider omission of RT, depending of course on all the other risk factors. So this is where multidisciplinary management really comes in. Now in patients who went for pre-op systemic therapy, adjuvant RT is based on the maximal disease stage at diagnosis. So even if you had a PCR, if the patient was N1 at diagnosis or T4 at diagnosis, then that is still an indication for their adjuvant RT. Adjuvant RT is usually given after the completion of chemotherapy, and endocrine therapy and HER2 targeted therapy may be given concurrently with RT. Next, nowadays we get a lot of young breast cancer patients in their 30s, 20s. So there are special considerations for young breast cancer patients. So any patient diagnosed, when we say young, that's 40 and below. So genetic testing and counseling is important. So we have to actually discuss this with the patient, give them referrals for genetic counseling, and they can actually even get free BRCA1 and 2 testing. For all patients of childbearing potential, we do pregnancy tests. And of course, we have to address fertility and sexual health concerns. So if you have a young patient, does not have any children yet, or still wanting to have more children after, then even prior to the start of their therapy, particularly if they're going for chemotherapy, you have to discuss considerations for fertility and options for fertility preservation, such as oocyte harvest and cryopreservation. Or in those who don't want, we can even give GnRH agonists while they're on chemotherapy to protect their ovaries. Now, important for you to know the indications for genetic testing. So as I mentioned, any young patient, so young I said 40, but for genetic testing, any patient diagnosed with breast cancer at 50 and below, that's an indication. Regardless of age at diagnosis, if they have triple negative breast cancer, multiple primary breast cancers, like if they have bilateral breast cancer, male breast cancer, or Ashkenazi Jews, or any of these. One close blood relative with any of these, or 3 or more breast or prostate cancer on the same side of the family, including that patient. So if she has 2 other relatives who had breast, ovarian, prostate cancer, then that would already be an indication for genetic testing. And it's important to do this because this may affect Our management, the patient might be wanting a breast conservation but finds out she has a mutation and opts to go for a mastectomy instead. Or the patient might benefit from a risk-reducing salpingo o oophorectomy. So it's important to know the indications for genetic testing. Similarly, this gives us further treatment options like recommending adjuvant PARP inhibitors like olaparib in BRCA1 and 2 carriers. For stage 4 breast cancer, there is really no benefit to doing surgery, and the primary treatment is systemic therapy. Surgery is sometimes done for palliation due to infection or bleeding. So when we have a patient who comes in with a recurrence, this is how we work them up. We do our history PE. Any patient with a recurrence, like for example, you did a mastectomy, you have a chest wall recurrence, we do a biopsy. And if it's proven to be a recurrence, then we do our staging scans. We have to do a metastatic workup to rule out distant recurrence. And of course, with our biopsy, we have to repeat ER, PR, and HER2/neu. Now, if the patient has a recurrence, we also recommend genetic testing and counseling because PARP inhibitors may be included in the systemic therapy that we give to patients with metastatic breast cancer. Now, if there is no sign of any distant metastasis, then we can still treat these patients with curative intent. So very important is the history of prior RT. In patients who had a previous lumpectomy with no prior RT, so we get a lot of these patients, they had a lumpectomy, it turned out cancer, they went for no other treatment, they come in with a new breast mass, so they never had RT. So if that mass is still amenable to a BCS, we can actually still do a BCS with sentinel lymph node biopsy and RT after that, or we can just go ahead and do a mastectomy and consider surgical axillary staging if it wasn't previously done. Now, if prior RT was received after breast conserving surgery, then standard of care would be a total mastectomy with consideration for axillary staging like an axillary dissection if they previously only had an SLNB, and discuss with Rad Onco if more RT can be given because giving RT with recurrences really improves outcomes. If the patient was previously treated with a mastectomy with no prior RT, then we do surgical resection if feasible and consider axillary staging. So, for example, post-mastectomy, the patient has a chest wall recurrence, then we do a wide excision. And then followed by post-mastectomy RT. However, if they already received prior RT, again, we try to resect it and discuss with the Rad Onco, can further radiation therapy be given? Now, there are certain instances where they come in with a chest wall or axillary recurrence and it is inoperable, too bulky. Then we may actually consider giving preoperative systemic therapy to downstage that tumor and then resect it and then send the patient for RT. For patients who only have axillary recurrence, if their initial surgery was an SLNB, then we go ahead and do an axillary dissection if feasible. If not, as I said, we can do pre-op systemic therapy, followed by RT again if it is still possible. If the previous surgery was an axillary dissection, then we at least try to resect that axillary recurrence. If it seems inoperable, we can give pre-op systemic therapy first, and then followed by RT again if feasible. Any recurrence in the internal mammary, supra, or infraclavicular area is really managed with radiation therapy alone. We rarely do surgery for these cases. Okay, so that ends the major bulk of my lecture. We're at the last part. I'm sorry if I'm maybe over time. So for special clinical situations, we'll go through them. Axillary breast cancer. So if you have a patient with no suspicious findings on the breast and just an axillary mass, core needle biopsy is preferred so that we can request for IHCs. And then if you have no findings on mammo ultrasound, MRI of the breast would help us determine if there's any occult breast cancer. So in MRI positive disease, ideally we also biopsy the breast mass and we treat according to clinical stage. But in MRI negative disease, then we treat based on nodal status. So if it is only N1, we can go ahead and do our MRM, or we can do an axillary node dissection with whole breast RT. On the other hand, if it is an N2 or N3 disease, we do neoadjuvant systemic therapy followed by our MRM. Next would be inflammatory breast cancer, which I mentioned earlier. It is a clinical diagnosis in patients with invasive carcinoma characterized by erythema and peau d'orange of 1/3 or more of the breast. A lot of times we have delayed diagnosis because these patients are managed as either cellulitis or mastitis. In more than 75% of women, they would already present with palpable adenopathy and even distant metastasis. And this characteristic clinical feature is due to blockage of dermal lymphatics by tumor emboli. And pathologically, the tumor is in the dermal lymphatics, but this is not required for diagnosis. So you don't need a biopsy showing tumor in the dermal lymphatics to diagnose inflammatory breast cancer. It's really a clinical diagnosis. So for treatment, it's always neoadjuvant systemic therapy. Always. We don't do outright mastectomy for these patients. And for those who do not respond, we shift to a different systemic therapy, and MRM is not recommended. If the patient still does not respond, we may even consider neoadjuvant radiation therapy prior to our surgery. Now, after neoadjuvant systemic therapy, the only surgical option would be a modified radical mastectomy. As conserving surgery and SLNB are not safe, reconstruction may probably be done further down the line once the patient has completed all of her treatment, but immediate reconstruction again is not recommended. And of course, radiation therapy is recommended as these are already T4B or stage 3B at the very least. So this is how we work up patients with inflammatory breast cancer. So we work them up as advanced breast cancer. If they have response to pre-op systemic therapy, we do our surgery and radiation therapy. If they're HER2 positive, we complete their targeted therapy. If they're ER positive, we give them endocrine therapy. If there's no response, we consider additional chemo or pre-op RT prior to going for surgery. Now, breast cancer in pregnancy usually presents at a later age because of changes due to lactation and the hormone-rich environment of pregnancy. Now, considerations for optimal local therapy and systemic therapy are essentially the same as patients who are not pregnant, except the timing matters. No, timing is very important. So to diagnose, usually we would just request for a breast ultrasound and do a core needle biopsy. Mammogram is rarely indicated because of the decreased sensitivity due to pregnancy changes, as well as if we have patients who really want a BCS, then we can actually do a mammo with fetal shielding, and the radiation delivered is actually very minimal and will not be detrimental to the fetus. However, normally, we really would not do a mammo and try to decrease the amount of radiation delivered to the fetus. For our staging, it's usually guided by clinical disease stage, and we want to minimize fetal exposure to RT. So for early cancers, X-ray and metabolic panel is enough. More advanced cancers, we add on a liver ultrasound, and we may consider screening with the thoracolumbar spine MRI without contrast. CT scan and nuclear imaging are contraindicated during pregnancy. And for surgery, surgery may be done on the first or second trimester. However, there is an increased risk of spontaneous abortion with first trimester anesthesia. BCS is still a very good option if the timing of your RT will fall after pregnancy anyway. So even if you have a patient diagnosed in the first trimester, even if you do BCS then, if the patient will need to receive systemic therapy anyway, that will last about 6 months, by the time she completes her systemic therapy, she has probably already delivered and can still receive radiation therapy. So actually, what's important for you to know about managing breast cancer in pregnancy is knowing the timing, the duration of the treatment, so that you can offer all best options to the patient. Sentinel lymph node biopsy is not done when the pregnancy is less than 30 weeks age of gestation, and we only use radiocolloid. All the blue dyes are contraindicated in pregnancy. Again, so everything is delicado, no? Pag first trimester, chemotherapy should not be administered in the first trimester. Also, it should not be administered after 35 weeks or within 3 weeks of the planned delivery to minimize hematologic complications during delivery. And so it's important for everyone to work as a team, including the OB-GYN, so that we can properly time the delivery of this patient. So trastuzumab and endocrine therapy are contraindicated during pregnancy. Radiation therapy is contraindicated during pregnancy. Now, we're all surgeons. Sometimes we forget ano ba yung first, second, third trimester. So I put it here. First trimester is 0 to 12 weeks. Second, 13 to 27. Third trimester is 28 to 40 weeks. So this is everything we already previously discussed. First trimester, you may discuss termination of the pregnancy, although in UST we don't do that. So if we have multidisciplinary management of this patient, we can actually very safely do these surgeries. No, so this is similar to what we already discussed. You may go through these guidelines. Next would be breast cancer in males, which breast cancer in males accounts for less than 1% of all breast cancers. It may be preceded by gynecomastia in 20% of cases and is associated with prior radiation exposure, estrogen therapy, particularly for those who were born male but opt to take estrogen supplements to develop their breasts, as well as patients with testicular feminizing syndromes and Klinefelter syndrome. The peak incidence is at the 60th decade of life, and approximately 80% of them are hormone receptor positive. As we saw in the indications for genetic testing, it is recommended for all males with breast cancer. And again, management is similar to the management in females, except regardless of age, our optimal adjuvant endocrine therapy would be tamoxifen. If it's contraindicated, for example, they have DVT risk, then we may give an aromatase inhibitor with a GnRH analog. However, tamoxifen is really better. Next would be Paget's disease, which is a rare manifestation of breast cancer characterized by neoplastic cells in the epidermis of the nipple areola complex, commonly presents with eczema of the areola, bleeding, ulceration, and itching of the nipple. So in 80 to 90% of cases, there's actually an associated cancer in the breast. And these associated cancers are not necessarily located in the retroareolar area. They may be in other areas. And they may be either DCIS or invasive cancer. So when the biopsy for the nipple areola complex is positive for Paget's, breast MRI is recommended to define the extent and identify additional disease. If you have IDC or DCIS, we treat as such. But if no associated and it's just really Paget's disease, then surgical options would be a central lumpectomy followed by whole breast RT, or a mastectomy with sentinel lymph node biopsy. So this is the flowchart and NCCN guideline. So if you have suspicion for Paget's disease, then we do breast imaging, mammo and breast ultrasound. Of course, if we have suspicious findings, we do a core needle biopsy. But if our mammo and ultrasound are negative for any breast lesion, then we do full thickness skin punch or incision biopsy of the involved nipple areola complex. If our nipple areola complex is positive for Paget's disease, or for example, we do a core biopsy and there's no other invasive or DCIS and it's really just Paget's disease, then we have to do a breast MRI. And if there are really no other breast lesions, then surgical option would be a central lumpectomy with whole breast RT or mastectomy with or without reconstruction with sentinel lymph node biopsy. So here you see, you may consider SLNB in a lumpectomy because when we do a central lumpectomy and if it turns out there's invasive cancer, then we can't do sentinel lymph node biopsy anymore. Okay, the last one is phylloides tumor, which are rare tumors comprised of both stromal and epithelial elements. But I think all residents will claim that in the Philippines, this is not rare. We get a lot of these patients. So phylloides tumors enlarge rapidly and are usually painless, and they usually appear on breast imaging similar to fibroadenomas. FNAB and core biopsy are inadequate really to reliably distinguish a phylloides tumor from a fibroadenoma, and the diagnosis is usually from an excision. So in the setting of a large or rapidly enlarging clinical fibroadenoma, excision biopsy should be considered to pathologically exclude a phylloides tumor. So these are the different types of phylloides tumor based on their cellularity and atypia, stromal overgrowth, the number of mitosis, and the margins. Treatment is by wide local excision with 1 cm margins. They rarely met to the axillary node, so we rarely do axillary staging unless you have pathologic or clinically palpable nodes. And the subtype of phylloides is less important for risk of recurrence than the margin. So it's very important to get at least 1 cm margins for these cases. So in the algorithm, so we have the suspicion of a phylloides tumor. We do history, PE, and our mammo and ultrasound. Usually, we do a core needle biopsy, not to diagnose phylloides tumor, but to actually rule out invasive carcinoma or DCIS. A lot of times when we do our core needle biopsy, it turns out indeterminate or maybe suspicious for a benign phylloides tumor, then an excisional biopsy is warranted. If it's fibroadenoma, we observe If it's borderline or malignant phylloides tumor, then we have to go for a wide excision. If it turns out to be benign phylloides tumor and we just excised it, we have positive margins, no need to go back for additional margins. We can just do clinical follow-up for 3 years, meaning annual mammo and ideally every 6 months ultrasound to watch out for any recurrences. No? So based on studies, benign phylloides tumors tend to behave more like fibroadenomas. On the other hand, if you have suspicious for borderline or malignant phylloides, or if you have a tumor already occupying the entire breast, then we do wide excision or a mastectomy without axillary staging. And we do our close clinical follow-up for 3 years. I think this is my last slide. Oh yeah, this is my last slide. So if you have a locally recurrent breast mass following excision of a phylloides and your biopsy proves it to be a recurrent phylloides or fibroepithelial lesion, then part of our workup would include chest imaging, ideally a chest CT scan, just to rule out any metastatic disease. Okay, that was my last slide. Thank you.
Thank you so much, Cola, for that. Very interesting and very comprehensive, as usual. So we have a lot of questions